up the volume. Get bearded. Let's start the show.
Welcome to Bearded Biomed. All right, everyone, welcome back to Bearded Biomed. If you just turned in, this is part 2 of our series of rural healthcare. Only now, the big beautiful bill is no longer a proposal. It is passed, signed, the ink's dried. Impact's already rippling through healthcare. So in this episode, I'm not going to ask what if anymore. Instead, we're going to ask what now? If you work in a hospital, especially in a rural one, this episode's for you. And if you're a biomed, this is my suggestive game plan for you. So we're going to dive deep because what's happening isn't a policy debate any longer. It's a shift in how care is going to be provided. So we have to be ready. Let's break it down. So the one big beautiful bill slashes Medicaid funding by over $900 billion over the next decade. That's not trimming, folks. That's a literal chainsaw to our rural healthcare system. It's going to add work requirements, restricts eligibility, and reduces retroactive coverage windows. It's going to cap state provider tax rates too, which indirectly is going to gut how states fund their Medicaid programs. So while it includes a $50 billion rural healthcare transformation fund, that's barely going to dent the damage that's being caused by the bill and the millions of dollars that they're going to lose annually on Medicaid patients as well. So for hospitals, especially in rural areas, this means they're going to tighten every budget line. Biomed departments are going to live in that gray zone, which we already are misunderstood. You can expect deferred equipment requests, reevaluating service contracts, freezing training, budgets, potential restructuring. The math is not in our favor. So picture this, you're one of 2 techs in a hospital, the OB is going to shut down, fetal monitors are moved, OR volume might drop, endoscopy towers not being used, ER starts scaling back, and equipment starts being untouched. As the services are going to disappear, the equipment's going to follow. Your workload's going to shrink, so your role might shrink as well, which isn't going to bode well for you showing your importance. There's going to be longer EMS routes for the hospitals. Pregnant women are going to have to drive further. Heart attacks are going to occur with no place to go. So for biomeds, we need to document everything. Track your PMs, your repairs, emergency calls, log your downtime, and really stress your regulatory compliance part as well. Audit your inventory. If you have aging gear, prioritize finding deals to replace it. You really want to strengthen your vendor relationships, but also try to bundle contracts as well. Lean on loaners. Share your risk profiles, quantify your value. I mean, suggesting alternative solutions to your leadership is going to be really crucial. So when I think about our value already, I mean, it's inherently embedded in the biomed ecosystem that documentation is important. You know, when it's time to have that TJC, DMV, CMS survey, CIHQ, whatever your auditory body is. That's really where the biomed shines, because when you have everything buttoned up and everything's tight and they don't have a lot of questions to ask because everything's right there in front of them, it makes you look valuable. So quantifying your data, like if you calculate like your downtime avoided, logging your hours, calculating your dollar impact of in-house emergency response, how much you were able to resolve internally versus the cost savings of utilizing a vendor or a third-party service, sometimes can be beneficial as well, depending on what type of equipment, what the service is. Really record like what your device to technician ratio is. So if this also goes well with justifying if you're understaffed as well, because with, let's say those departments I mentioned before start shrinking. If you have a set amount of equipment and it's supposed to, like the AMI numbers, for instance, that they're supposed to be based on how many devices a technician is supposed to handle yearly, and they're talking about letting somebody go and you have set number of devices, you can use those device to technician ratios along with downtime to really support and keep people from leaving let go. You want to be tracking, and hopefully you are, the number of age units that you're, maintaining that are past that threshold, which a lot of the stuff made back then is really well made. And there's been numerous studies that you don't have to go with the latest and greatest. There's stuff still in use 30, 40 years old that's humming fine, but you want to be able to track that stuff. Like I was recalling before, your compliance metrics, so like your PM statuses, or your recalls, your uptime gains, track your progress year over year, days of patient cares that were saved where they're not having to turn away cases because of the capacity of what you were able to provide in emergency or even daily situations. Repurpose stuff as well. So if you have devices that maybe came from closed departments, if you can repurpose those for other departments, that way you're not losing devices, as well as it could also help subsidize some of the departments that need stuff that didn't have prior. Really take a large scope picture of, all right, let's just say an OB department closes. Well, obviously a fetal heart monitor isn't going to get used in like general PACU, but there's a lot of equipment that, for instance, infant warmers, stuff like that, those can be reallocated to OR because you still want to be able to have those in the event that, you have an infant that needs to be used on that, needs to have that piece of equipment used. Thinking as well, you want to use what I like to call just-in-time parts. I think the way the parts ordering over the years has gone. As Biomeds, we don't need so much to rely on having a vast stock of parts, but there are certain parts that you want to have in case of a critical down that you need to have those on hand. That's still going to exist, but it would also help to look into the parts that you guys have and determine, like, we have all these, we haven't replaced any of this stuff in years. Maybe we can sell it, get some of that cost back. Or again, this would help you identify too, maybe there's devices that are constantly going down and you don't have parts on hand. Overall, from a general biomed perspective, outside of this conversation with rural health and Medicaid cuts, it's good to have a general idea of what parts are constantly going in and out, which ones you need to have basically readily available. So the other part of that is definitely doing a contract sweep. So typically, from what I've seen outside in and other contracts I've managed over the years, when you start talking about you're going to go and, start doing price comparisons, typically that's where the discounts will start rolling into, because vendors don't want to lose you. So whether it's third party or OEM, renegotiate when contracts are up, because that's your leverage to really cut cost, and also maybe explore taking some of that work inside as well to further validate your importance to the facility. This goes without saying too, but really leaning on user training as well. So more often than not, we've all had the call at some point in our career. Did you plug it in? Did you charge it? There's certain trainings that you can really put towards staff and emphasize your knowledge base to get the staff to where you're able to avoid calls that didn't need to happen to begin with. That way you can repurpose your time to things that matter. But again, having that training aspect where you're talking to staff and being a resource, again, that's perceptive value that the staff's going to see. I would also probably recommend resale options. This is really big when you're talking about possible downsizing, cuts, department shrinkage. There's so many resale options out there nowadays through third-party vendors, even donation strategies too. So some of the more common like resale options, like I've seen people use are like .med. You got your block imaging. Vontae's done some of that stuff too. Your CMMS should facilitate this, but you need to have an actual like catalog of all the devices you guys have, and track, how old they are, the parts that have gone into them. The resale visibility is going to be on it. Especially now, let's say if you have something that's just really not worth going through the trouble of doing a resale, that's when you want to look at donations. So your med share, your project cures, your global medical aid, like those are things that you can use that will either help another rural health hospital out there that can support them with, maybe they don't have the funds to go after something, or it's going to support third world initiatives as well to get them the equipment they need to keep it going, because a lot of the stuff we throw away in the US lasts even further down the road in a lot of these countries that just don't have the connections or the infrastructure to go after these devices. So you want to be able to get the most out of it you can, even if it comes with or without a write-off of the value. It's helping the community, and obviously it gets rid of the, what I like to call the bunker, or the storage that every hospital has. The main thing with that is you want to make sure you're complying with all FDA transfer guidances. When you're talking about PHI, any personal data that might have patient stuff on there, you got to make sure to dang near reset it to factory default, so you're abiding by all those regulations too. You got to be vocal, and you got to share your stories of successes and failures to leadership. So making it known that you were able to successfully do this, and a case was able to get up and continue, because if cases get canceled, that's funds lost. But it's also good to share the stories of particular failures due to not having certain resources, certain support. I mean, you can't just have nothing but success stories, especially when you're talking about your importance inside a facility, because we all have our constraints. From myself as a third party independent service provider to you guys that are in-house, everybody has their challenges. And if you're not voicing those challenges, then they're never going to get solved. Now, to caveat on that, this goes across the board with C-suite, but typically, if you're going to come with the problem, it's going to happen one or two ways. They're going to be like, oh yeah, that makes sense, or yeah, we don't have the money or the funds for it. So if you're coming with a problem, try to tackle a solution that possibly could save money by going with your solution as well. So I guess to cap this off, you stay informed, definitely network, share as much information, document everything, and help everybody in your facility understand that you are vital, that this is going to be a long road. Unfortunately, none of us wrote this law, and all we can do is adapt and show leadership, be visible, be the difference in our system that's going to be under stress. There's a lot of facilities that, like I said in the previous part one, I talked about are teetering on the line or are already in the red. And unfortunately, with this bill, we are going to lose some more hospitals. It's inevitable. The best thing we can do is to support each other the best we can, and really share this information and share solutions and strategies to support one another. I hope between part one and part two, you guys got some good information out of it. I appreciate you turning into Bearded Biomed. If this episode helped, if it jives with you, please like, subscribe, share it. Get this message to every person that can seek value from it, because at the end of the day, information, knowledge is power. May the beard be with you. Appreciate you. Take care.
Biomed.